هنبدا النهارده ان شاء الله. دكتور احمد تاج هيكلمنا على الكونتمبوراري امبلمنتيشن في الكلينيكال براكتس في الهارت فيلير.
Ischemic heart.
في الاسكيميك هارت ديزيز.
Ischemic heart disease. Yeah. بسم الله الرحمن الرحيم. I'm very glad to be here with you all, and I'd like to thank my colleague Professor Mahmoud Sabbah for his very nice intro, who has done for my presentation. Ischemic heart disease medical treatment works. Yeah, it's really working. Over the past 2 days, we have very important presentations about intervention aspects in coronary artery disease and structural heart disease. We have some cases of TAVI for my colleague Mahmoud Sabbah yesterday, and some other important presentations in complex interventions, left main, CTOs, and all those stuff. However, still there is a room for medical treatment in patients with coronary artery disease. And we can start, I'll start here with thanking Menarini Corporation for their support for our meeting. I'll start with a quote for Socrates, who came actually from the ancestor of Professor Manolis. If you always do what you've always done, you will always get what you've always got. So when it didn't work, you have to change your mind, simply. You have to think out of the box, or out of the fridge, as they say. So this is the important statistics about the atherosclerotic coronary artery disease. Actually, the prevalence of coronary artery disease is 1%. Cardiovascular disease mortality in Egypt, 46%. LDL control in very high-risk patients is 10% or less. So these are some sort of astonishing and actually shocking data about the atherosclerotic cardiovascular disease worldwide in Egypt. So I'll start with 2 clinical scenarios which we can use important medications to improve patients' quality of life. So this is Mrs. MK, 58-year-old lady. She's a smoker, presented to outpatient clinic with chest pain on moderate exertion over the last 3 to 4 weeks. She had undergone CABG 2 years ago. She's non-insulin dependent diabetes for 5 years on medical treatment. She didn't follow up for 1 year. Yeah, this actually happens. When the patient feels himself well, he took some medications or did some surgeries or had stent, he didn't follow up if he doesn't feel any problems. However, he should follow up, actually. He must, actually. No history of syncope, palpitation, or recent hospitalization. She looks well, conscious, oriented to time, place, and person. Auto saturation is okay. Vital signs, heart rate 58 beat per minute, blood pressure 100/65 millimeter mercury, temperature, respiratory rate okay. No lower limb edema, but faint distal pulsations indicative of peripheral arterial disease. Apical systolic murmur with S4 and the apex outside mid-clavicular line, no thrill. Chest was clear, abdomen lacks no organomegaly, and this is the lab of this pleasant lady. Are you happy with LDL target? 119 milligram per deciliter. What's the target for this lady? Actually, less than 55. And if she's suffering from 2 events or more in 1 year of atherosclerotic cardiovascular disease, the target as class 2B guidelines in the European Society of Cardiology is less than 40 milligram per deciliter. Anyway, she's not on target. And hemoglobin A1C is not controlled, 7.5 as well. So these are the medications she is taking for her condition. And so what's next? Should we change her medications? Advise to stop smoking? Of course. Order some investigations? I think, of course, all of the above. So all of the above, yeah. This is her ECG, and you can clearly see that she's bradycardic, and she had left bundle branch block, which could be one of the manifestations of ongoing process of ischemic cardiomyopathy or even ischemic heart disease. This is her echocardiogram, dilated LV, ejection fraction 45%, mild mitral regurg, degenerative valvular heart disease, ekinetic LAD territory. And that's her multi-slice CT coronary angiogram. She had patent lima, graft to diffuse disease, LAD, multi-slice CT coronary angiogram, and they are indicating that lima is patent. However, LAD is diffusely atherosclerotic. So what's next? Should we add beta blocker? Should we add ranolazine, Ranexa, one of the important medications for management of chronic stable or coronary artery disease? Should we increase ramipril dose? Should we increase nitrates dose? And if we see these 6 important, I would say, phenotypes of coronary syndrome, she will be in this one symptomatic or asymptomatic patients more than 1 year after initial diagnosis or revascularization. In this case, she had CABG. I think this important guidelines is very important, practical, and easy to use, if you could say. And this was at 2013, I think. And it has changed a lot. However, this is the most simplest one. For coronary artery disease management, we have event prevention medications and angina relief medications. Both are important. Event prevention is usually associated with improvement in mortality and improvement in the outcome and improvement in hospitalization. And this includes lifestyle modification, stop smoking, control of risk factors, aspirin, statin, and ACE or ARBs, with consideration of revascularization at any stage of the initial evaluation. Angina relief, again, very important. However, they usually affect quality of life, sometimes hospitalization, rarely mortality. So we have beta blockers, which are very important. Sometimes calcium channel blockers, if we don't have LV systolic dysfunction, and this lady had LV systolic dysfunction, so it's contraindicated. Then this first line, and then we have second line medications, including ivabradine, long-acting nitrates, nicorandin, ranolazine, and trimetazidine. So we have actually many important medications that we can use for the patient seek of improvement and improvement of quality of life. So according to the new one of the algorithm for management of coronary artery disease, this according to the heart rate, if it is less than 60, we have to look at blood pressure. If it's less than 120, so actually it's important to use ranolazine in such a patient, and this is actually applies to Our Lady. So we have other different points, but what to do next? Add beta blockers, ranolazine, increase ramipril dose, or increase nitrates. Why ranolazine? Heart rate is 58, so we can't add beta blocker or even ivabradine. Blood pressure is 100/65, so we can't increase the dose of ramipril. However, increase of the dose of ramipril will prevent event, but will not manage angina. This is the point. Increase the nitrates dose possible, but blood pressure is low, and sometimes, and many times, nitrates might cause tolerance or tachyphylaxis. So it's wise to use ranolazine for this lady. So after adding ranolazine for this lady, which is Ranexa 75 milligram twice daily, we usually start with the lowest dose and upgrade to 750 milligram twice daily. So in 3 to 4 weeks, angina frequency and duration reduced remarkably. She stopped smoking, and we controlled, of course, the LDL by statins, and started to walk for 30 minutes per day, and this is important in the event prevention and actually relief of successive possible bouts of angina. So we have another patient, which again we can use ranolazine or Ranexa in management of their condition, like Mr. A.N. Mr. A.N. is a 68 years old gentleman, hypertensive, insulin-dependent diabetes mellitus, dyslipidemia, and smoker, presented at Bush Clinic with chest pain on mild to moderate exertion a few weeks ago. No history of syncope, palpitation, or recent hospitalization. Looks well. Again, his parameters are appropriate. No thrill, no murmurs, but SC3 is there. And this is the lab for him. Random blood sugar is not controlled. Hemoglobin A1C, again, is not controlled. LDL is very high, 189. So this is the current medication for this patient: ramipril 10 milligram, nebivolol 5 milligram once daily, clopidogrel, and the mononitrates on demand, empagliflozin, Lina with metformin, and atorvastatin 40 milligram, and aspirin. So what next? Should we advise the patient to stop smoking? Of course. Should we order some investigation or both? I think both. So this is his ECG, resting heart rate about 67, and you can see T-wave inversion more prominent in EVL, and we have some sort of flattening of the T-wave in the lateral leads. This is his echocardiogram, normal LV size, ejection fraction accepted, trace MR, degenerative valvular heart disease, but no segmental wall motion abnormality at least. So this is his coronary angiogram. You can clearly see that the patient has some sort of diffuse ectasia of coronaries, as you see all over here, and we have some evidence for significant atherosclerotic cardiovascular coronary artery disease. However, the size of this artery, which is a branch of the left circumflex artery, is less than the size of the catheter. So it's a small artery. However, it can represent itself with the patient. Again, we have another atherosclerotic vessel, but it's tortuous, as you could see here, and ended up with, again, another ectasia. Again, he has ectatic right coronary artery. His provisional consultant, who he's following with, actually advised him to single vessel PCI. Another consultant advised him to take medications only, and then we can see whether he will still need intervention or not. Patient, after adding ranolazine or Ranexa, has mild angina on moderate exertion. What to do next? So increase dose of beta blockers. We have already added ranolazine. Increase ramipril dose or increase nitrates dose. And the answer is we can add, again, ranolazine for those patients who are old. They have evidence of coronary artery disease, and their intervention is still there, but possibly we could do it or not, because the patient already is not on a STEMI or non-STEMI. He just has some angina, which relieved by maximization of all medical treatment he was taking. And this is another place for adding ranolazine in patients with coronary artery disease. So current status: within 2 to 3 weeks, angina frequency and duration reduced remarkably. He stopped the smoking, started to walk 30 minutes per day, no more angina. And this is how ranolazine works. Ranolazine is a chemical component which does not only work on the arteries, it works in different metabolic and electrical and mitochondrial and myofilaments. I think this table, I got it from one of the FDA insertion leaflets for the ranolazine. It has effect on metabolism, increase the amount. Is there any problem, شباب؟ الشاشة بتلعب. كنت حاطط ده أنا. Okay, so it has effect on metabolism, increase the amount of active dephosphorylation of pyruvate dehydrogenase, effect on sodium current, late sodium current, and this is the important one that reduces ischemia. It improves mitochondrial work, and mitochondria is very important inside the cardiac myocytes, and it has some important effects on myofilaments with calcium sensitivity, so it improves even contractility. So there is some investigation work on the effect of ranolazine in patients with heart failure. However, the current indication is only for management of coronary artery disease. Actually, it works. It doesn't work on heart rate, actually. It has some room in heart failure, and we can give it in patients with heart failure, COPD, even if they have AV conduction abnormalities, in AF, macrovascular angina, diabetes. And this is how it works. في مشكلة شو? I think there is technical problem. Okay. So this is one of the important mechanisms, of ischemia that increase in the late current of the sodium gates. This leads to sodium overload, calcium overload, and this leads to arrhythmia, leads to diastolic dysfunction and dysfunction of contractility, and it leads to reduction of ATP formation and increase of ATP consumption. So the end result that it will increase the ischemic burden on those patients with coronary artery disease. So if we block this late sodium current with ranolazine or Ranexa, actually, so we block this pathway which leads to coronary artery disease. So it will reduce burden of arrhythmia, increase ATP formation, reduce consumption, and improve diastolic function. And this is the guidelines of the European Society of Cardiology, which was updated, I think, in 2020, and then there is another update last year. However, no big difference. Again, this is the same one which we looked at 2013 or 2012, I think, but they have their segregated according to the standard therapy, heart rate, blood pressure, presence or absence of LV dysfunction, presence or absence of low blood pressure. So usually either the EACC guidelines or the American guidelines or even the NICE guidelines, there's a room for ranolazine as one of the second-line therapy for management of chronic coronary syndrome, and you can add it with the event preventers and with the angina relief medications including beta blockers or calcium channel blockers whenever indicated. And it's important in relief of symptoms of angina, improve quality of life, improve 6-minute walking test, and reduction of frequency of angina. This is, I'll end with just 1 minute, I hope. Patients with angina or dyspnea and coronary artery disease, ranolazine is class 2A indication as second-line therapy with the first-line therapy of event prevention and coronary artery disease frequency prevention. And it could be 2B in subjects with baseline low heart rate because it doesn't affect heart rate, it doesn't affect blood pressure. And in selected patients, combination of beta blockers or calcium channel blockers with second line could be considered first line in indicated patients who are suffering from coronary artery disease. So ranolazine, according to several trials and several meta-analyses, actually adding ranolazine and other may improve benefits of the combination with beta blockers, calcium blockers as first-line therapy. However, no data was available in this review for nicorandil. I reached my take-home message, my dear colleagues and chairman. Medical management of coronary syndromes, actually they are heterogeneous group of patients with the same entire important disease, atherosclerotic cardiovascular disease, atherosclerosis. It's important to start with event prevention, as I said before, including ACE or ARBs, B2Y, inhibitors, statins, and aspirin. Angina relief medication should be initiated in all patients, and this includes beta blockers or calcium channel blockers, nitrates, ranolazine, and ivabradine. In selected patients, combination of beta blockers with second-line drugs like ranolazine may be considered from the start as first-line therapy. And these are the guidelines I explained before. These are the coronary syndromes spectrum. Which patients group will benefit from ranolazine? Coronary artery disease and diabetes, coronary artery disease with atrial fibrillation, coronary artery disease with normal coronaries, coronary artery disease with contraindication to many other anti-anginal medications, either due to tolerance, due to hypertension, bradycardia, or so. Monotherapy in coronary artery disease as add-on therapy. Coronary artery disease who are at high risk for revascularization after successful revascularization. Okay, coronary artery disease in the elderly. It's safe in elderly population. Ranolazine's anti-ischemic and anti-anginal effects don't reduce heart rate or blood pressure, and that's why you can use it safely in patients with coronary artery disease. Thank you so much, and I hope I didn't exceed my time.